Good afternoon, everybody, and thank you, Team AIOS, for giving me this opportunity. So let's start with some unique refractive surgery complication. Here is a patient's details. Patient is having -3 myop with normal topography and pentacam reports with the 500 pachymetry. So everyone could consider it as a routine normal LASIK case. So we have also considered it as a routine case, and we have started the treatment as per the normal norms. So I have taken the flap with the SBK motor. So as we all can see, the flap is absolutely fine. So if many of us are thinking that if there is no flap related complication, then what else it could be. Flap is absolutely fine. So I have started the treatment. Laser is firing, and suddenly something has happened. No one could make out what has happened. So the what has exactly happened is I was in the middle of the exam laser and the treatment has not completely done, and suddenly the machine has turned off because of the power supply or because of the UPS failure. So what generally we do, normally we all do, we are just reposit the flap back and wait for the 1 to 3 months and doing the reposition or the PRK afterwards. But here what I did, I retrospectively I memorized that I had my eye on the vision on the laser progression bar, and I exactly knew where the machine has turned off. It was exactly at 48%, right? So what I did is I turned on the machine and I just entered the data of the patient again. And what was my aim was I need to start that treatment exactly from the 48 percentage to the patient's eye. So what about the initial 48 percentage? I did that initial 48 percentage of the treatment on the PMMA plate or the fluence card. And here I did this the same. Here is a calibration of the machine and patient's data. I have started the patient's treatment, and I am going very gradually because in that way I have the control over the laser firing. So I'm giving the laser on the PMMA plate or the fluence card, and when exactly it reaches to the 48 percentage, I stop the foot switch and I switch over that treatment to the patient's eye. Here it reaches to the 48 percentage, and I switch over that treatment to the patient's eye. Here the laser firing is on the patient's eye. I've started the foot switch and the laser is firing, and I've completed the laser treatment. So, and the rest of the procedure the same way as normally we are doing, putting the flap back, putting the BCL on. So everyone would think about the end result. So on the next follow-up day, it was plus 0.25 and plus 0.5. Visual acuity was 6/6, and patient is absolutely fine. Patient doesn't have any complaint. Even after 1 month, the autoref was 0/0 and visual acuity was 6/5, and patient did not have any complaint. Patient is absolutely happy. So what was a take home message is do not get panic when the unexpected things happen, and always keep an eye on the treatment progress bar also, along with the eye on the patient's eye also, and periodic checkup of the power supply and the UPS is needed. So coming to the next complication, this is the femtosecond procedure, and I have taken the femtosecond flap with the superior hinge with the intralace machine. Flap is absolutely fine. Before lifting the flap, I have marked the cornea. Now I'm starting lifting the flap. The dissection was a little bit difficult, and so I was doing very gradually. When I was in the middle of the flap, suddenly the patient became very uncooperative, and patient started moving his eye here and there, right and left, up and down, everywhere, but not in the center. See, so what, something has happened. We could not understand what has happened. I have not completed the dissection inferiorly, but the flap has torn from the superior side. So I started setting it very gradually, very slowly, and fortunately I have not did the dissection inferior side, so the flap was attached there only. See, let's see it again. When I was in the middle of the flap, because of the traction, because of the traction of the instrument and traction of the hinge side, suddenly the corneal flap has torn from the superior hinge, not exactly from the superior hinge, just below the superior hinge. So I have converted the inferior attached part as a hinge, and I have converted the superior hinge into the inferior hinge, given the laser, and put the flap back. And I have put the BCL on top of it and completed the procedure. On the next follow-up day, the flap was absolutely stick to the cornea, and patient is absolutely happy. Thank you so much.
So very nice videos, Dr. Kanan.
Yes, thank you, sir.
First case, as you already mentioned, the most important thing is to ensure that UPS is in place and
Yes.
working properly,
Yes.
rather than managing the patient.
Yes.
In the second instance, however, uh, if I was there in your place, when the patient was moving the eye very vigorously, I would have removed my instrument, given few minutes for the patient,
Okay.
I was spoken with the patient,
Right.
relaxed her, and then I would have started again. Probably then we never have had this complication at all.
Right.
So probably that is one place where uh, you could have shown a little more patience.
Yes.
But at the end of the day, you manage it very well.
Yes.
So then all is well that ends well. So it's okay. But so next time, anxious patient,
Yes.
first thing, if the patient is anxious,
Yes.
we need to increase our patience multifold.
Yes.
Okay, we have to compensate for their lack of patience.
Yes. Yes. Yes.
Huh? Very
Yes.
nice videos.
Sir, can we do one thing, as if the flap is of the superior hinge, so we need to start the dissection from the inferior side. So,
Excuse me. May I?
Yeah. Ambarish bolo.
I feel that normally the dissection, once you start, because see, these things means, of course, patience matters, but these things happen in a fraction of a second without even you being realized. So normally, femtosecond flap I have seen, when you start from the middle of the thing and start separating towards the inferior portion, things become very normal, and the amount of traction which was created because of opening from superior side, the traction becomes much less when you start from the middle. So apply your from middle to the inferior side, and the flap separation becomes quite easy.
Yes.
And the moment that OBL is gone, even your patient becomes comfortable.
Right.
Right.
So that's what I learned after 3-4 surgeries, that I have to start the dissection from the inferior side.
Everyone has gone through the same phase. So you have courage to show that.
Yes.
Exactly, I was telling you there. I have gone through the same things. It's not the FAM2. I was managing a enhancement, and I was not sure whether the patient has gone through SBK or this MK2, because the position of hinge is different. So somehow I tore the hinge, but still the portion of this flap was intact. So I used that portion as a hinge. So you can use any portion as a hinge. It doesn't matter much. Yes. So only thing, it should be intact in that part. Say around 0.5 millimeter is there. That's more than sufficient. You can manage it very well.
Yes.
That's a good thing.
Yeah,
I got the same surprise in while relifting the flap.
We must appreciate her presence of mind for both the cases. The way she thought,
Yes.
it's out of the box thinking.
Yes. Thank you, sir.